Okay, we're about a minute past, so I'm gonna go ahead and get us kicked off. I've got the double duty of getting people into the room and introducing our speaker today, so bear with me if you see anything moving all over the place. But welcome everybody this morning. Thank you for being here. My name's Ryan McCullough. I am with Gallagher. I am your programs director for 2026 for SHRM. And we have a great session today with Miley Hong from my company, Gallagher. A couple of housekeeping items before we get started. If you do have any questions, please feel free to drop those in the chat as we're going. If anything is a little bit more complex or you want to come off mute, I can unmute you. Just make a comment in the chat that you'd like to come off mute. We'd like to save the discussion for the end, so try to stick to the chat for questions as we go forward. But like I said, please hop in with anything as it comes up. We did have a great session today on all things pharmacy 2026. So Miley is going to walk through GLP-1 strategy, PBM directives, a lot of things that should be on your radar and are ever changing throughout the year. So a lot of great information today. But with that, Dr. Miley, I will go ahead and introduce you, and I'm going to read this, so bear with me as I read through your impressive bio. Dr. Miley Hong specializes in providing pharmacy consulting services with Gallagher. As Area Vice President, Dr. Hong's primary focus is to help clients manage their firm's pharmacy benefits and spend. Her strong analytical skills and clinical knowledge allow her to assist clients to navigate through the complex and dynamic pharmacy marketplace with confidence. Dr. Hong joined Arthur J. Gallagher in April of 2018. She's a licensed pharmacist and has over 25 years of experience in managed care, including different roles within pharmacy benefit managers, or otherwise known as PBMs, companies, and as a consultant. She's a graduate of the University of North Texas with a Bachelor of Arts in Biology and French, and she received her PharmD degree from the University of Houston College of Pharmacy. So please welcome Dr. Hong, and I will turn it over to you once I click stop sharing.
Right, thank you.
And see if you can take it from there.
Sounds good. Let me know if you are able to see the screen.
There it is.
Perfect.
Awesome.
All right. So thank you for the introductions today, Ryan. I've been practicing pharmacy in the space for over 25 years, as noted, but it's ever changing and my job is not boring. And for that reason, I'm excited to see participants. And first, thank you for joining the meeting today. I hope to provide some insights to you in terms of the dynamics and the highlights that we have from our book of business, and also some forward-looking solutions and practical solutions to help you maintain your costs. And with that, we can look at the agenda. We'll be focused on the emerging trends and solutions, and there's so many of them. So I will focus on GLPs and specialty drugs because these really are what's driving our clients' spend for the most part under pharmacy. And then let's evaluate pharmacy contracts a little bit, touch upon what we're seeing in terms of changes, and perhaps changing the pricing model requirements from the PBMs to get a better, more transparent contract with the PBMs. And then, of course, Q&A sessions toward the end. With that, let's start the meat of the call. So the first thing we ask our clients is that, what are our employers most concerned about? And what we received from this survey that was conducted through 2025 is that our clients are worried. Their top concerns are rising healthcare and pharmacy costs, with 98% of respondents saying that drug prices are what keeps them up at night, right? And so the complexity of managing pharmacy benefits and the escalating trends that we're seeing with high cost therapies. So the overall message is that, to me, pharmacy spend and medical cost pressure, these are strategic priorities for our employers. And just to take a note back, and because when I talk about drug prices, when I just graduated and joined the PBM world, managed care world, the primary focus for my clients at that time was, how do I pay for this $200 Claritin prescription or how do I pay for this, $100 prescription for a blood pressure medication. Since then, things have evolved quickly. And when new drugs come to the market, that pricing is really inflated as compared to what it was about 25 years ago. So that's what keeps things changing and interesting on my end from that perspective. Now, what's causing heartburns for us and for our employer groups? What are the emerging pharmacy trends? So this is what we have in terms of pharmacy trends. We have our GLPs. GLPs, as these are good, valuable drugs, but the question is, they continue to drive utilization and spend, especially with a new oral medication for Wegovy that just came out for the weight loss version. Um, we anticipate that there is a need, or that the market share will increase for will go with the oral version, because there is likely a group of folks who have been waiting. There's pent up demand for these oral medications, especially if they're not comfortable with it, with injecting themselves for weight loss, right? And then we also have expecting Eli Lilly to submit their oral versions and coming to market soon with that. And with the GLP category, it's not just the formulation that's changing, it's also the additional indications that they are seeking. They continue to seek to expand their market share within this category of drugs. And then we talk about specialties. Specialty drugs, for the most part, is now about 40 to 50% of our clients' pharmacy costs. And keep in mind that this substantial cost for our clients is really driven by a handful of folks. About 2 to 3% of the population are using specialty medication that's driving this level of spend. And when we look down the pipeline, that continues to be robust. And it's interesting because specialty drugs, when again, when I just started, I think one of the first to market drug was Copaxone for MS, for example, and that really was a game changer for our clients, for the therapy itself, because prior to that, MS did not have true therapy to mitigate or minimize the relapsing and remitting episodic condition associated with MS. Instead, what they were treating were putting our patients on steroids and try to treat the symptoms, but not the progression of the disease per se. So when Copaxone came out, and that was about $1,500 drug, that totally changed the dynamic from our clients' perspective. And then rebates start becoming more and more important during this time as these branded products, these specialty drugs start coming to market. And other emerging trends that we're seeing is that there's a lot of more point solutions for our clients to manage weight loss, manage specialty, carving things out for better management. So there's a lot of information out there, but we really have to be very thoughtful in the process. Do these point solution vendors, do they make sense? Does the ROI, is there an ROI? How is the program designed, and how is the ROI guaranteed paid out? So there's a lot of metrics or pieces that we need to evaluate for each point vendor solution. Does it make sense for our clients to implement them? Transparency has always been an important word, but the transparency, the more and more we look at contracts, and the more with the market dynamics changing, transparency really is a very opaque word from my perspective, right? And then we also talk about fiduciary responsibility. That's becoming more and more important in terms of seeking the best pricing or the lowest net cost for our clients. As you can likely aware, there are some lawsuits from employees suing their employers by saying, hey, you did not provide me with the lowest net cost. Think about Johnson and Johnson, JP Morgan Bank, etc. So a lot of these are very important emerging trends that we have to address as employers and as a consultant on our clients' behalf. And with that, we also will be touching upon the pricing model. Does the current one work? Is there a better model out there? All right. So let's switch over to let's move on to the GLPs, and we'll focus on that and what we know about GLPs at this time, right? So GLPs, as mentioned, they're good drugs. They can provide meaningful, life-changing impact on a client, but they are expensive. They are about $10,000 to $12,000 per year to treat a patient on a GLP, whether it be diabetic or weight loss. The problem, though, is that the median duration for these drugs are only about 6 months. What does that mean? That means that our patients are not being adherent or complying with what for these medications. So clients are not seeing that the health benefits that we would like to see by paying for these drugs, right? So the discontinuation rate that we're seeing is that up to 40% of patients discontinued therapy within the first year. That's an area of improvement that we need to focus on. And we also have to consider some of the adverse events may increase medical cost. For one of my clients, when I did utilization, a deep dive into their pharmacy spend, for example, I began to notice, why do they have this drug Linzess that's used to treat chronic idiopathic constipation? Why are so many of these patients are also on GLPs? Like, it looks like the pattern was they would start on GLPs, and then the physician or prescriber would layer on this drug to help manage that side effect of constipation associated with these GLPs. And so we have to consider that added cost as well. And as mentioned earlier, there are a lot of point solutions out there. Verta, Vita, Tria, all these, they're looking to supplement any kind of lifestyle modification programs, provide additional care management to really maximize the dollars that you're already spending on these drugs, right? But the problem is the point solutions, they all have that they have similar goals, but they have different ways of achieving that. And is it effective or not? And the cost of the program, does that make sense on top of the cost of covering these GLPs? And so at this time, what I'm seeing with fully insured plans is that they typically consider these as a cosmetic exclusion, so they're not covering them. On the self-insured side, for my clients who are covering them, they're now asking us, what solutions can we bring? What can we do to minimize this impact that we're seeing with our dollars, with our pharmacy bucket? Okay, so what we did at Gallagher is we looked at data for our book of business to show, what are we seeing? We're paying for these medications, but does it mean that is it really impacting and reducing medical spend and improving quality of life for our patients? And so what we saw is that in 2024, the class exploded. There was an increase in 35% of GLP spend in dollars. And then in 2025, when this analysis was conducted, we saw an increase of another 25% on top of that. So it suggests a continued increase in spend that we're paying for these GLPs. Now, what we did see was the diabetic population and the overweight population did have a benefit. There was an 8% lower medical trend with decrease in hospitalizations and heart attacks. But the problem was that there's a bigger picture out there when we take a step back and say, look at all these patients who were on it, but were not consistently on it, and we're not adherent to it. The overall cost of the GLPs was more than what the value of the decrease in the medical spend was. So for an example, it's estimated that Wegovy would cost about $274,000 over the lifetime cost for a patient, right? But the projected medical cost offset is about $60,000. So we're looking at an overall net of about $200,000 in spend that we have on these GLPs per patient. So at this point in time, there's not a true value that we can perceive at this time for the overall aspect. All right. So this slide I wanted to show you and share with you what we're seeing for the types of groups that we have covered. So as you can see, we broke this on the left side. We broke down the information paid PMPM by industry, by weight loss coverage, right? So the light blue line are those that do not cover weight loss, but we still cover GLPs for diabetics. So the implication is that this is just for diabetes, but we know that there has been some leakage from the weight loss use on the diabetic GLPs. So the dark blue line indicates for the PMPM spend for those that do cover weight loss. And so as you can see, one of the biggest spend, and this is truly reflected based on what I have, is like our public entity sector, the government sector. If they cover for weight loss, the average spend that we're seeing is about $60 PMPM for weight loss, for their GLP spend for weight loss. And then the what we see, and keep in mind that if you look on the left side where the spend is coming from, the spend comes from the majority of utilization is from females within the age group of 40 to 60 years of age. And so that's where the focus of the spend would be. And then when we also look at what the PMPM spend is for our clients that covers weight loss, it's on average, if you look at the left side, the average spend of that is about $39 compared to those groups that only cover cover GLPs for diabetes and roughly about $25 PMPM. So there's a huge disparity. There's a huge difference in cost when you cover the weight loss. So having said that, what can we do to help our clients manage these drugs and manage them well and really maximize the dollars that they're spending? So when we look at some of the options, some of what we lay out here is if you look at the arrows from the left to the right in terms of coverage for the membership, that's the lowest coverage to the richest coverage on the right side. But when we look at the health plan cost, then it becomes flip-flop. So the highest cost comes from the right side. If you carve in coverage with a PBM versus excluding it, right? So some options to consider. And when we work with our clients and they ask us, what can we do or what should we do? This is we work with our clients to understand their needs, what their culture is. And so, for example, some of my public entities like school districts, and they're competing for talent with the district next to them, they'll say, hey, we understand the cost, but we need to continue covering because we're trying to recruit and retain. And so it just depends on the culture and what the client is trying to achieve. But some of these are the options. Some of our clients say, we don't want to have any coverage at all. This is too much. We're not seeing a value. So our suggestion is carve this out, guide the patient to direct-to-consumer pricing. And as you are aware, with Trumper X or with direct-to-consumer, with Novo Nordisk or Eli Lilly, they're offering this much lower competitive pricing out there for a patient to get to get these drugs outside of their benefits. They just simply go onto the website and enroll, submit their prescriptions, and then they can receive these products. There are injectables and orals that was recently proved they're available out there. The orals are about, on average, depending on which strength, it's quite substantially lower outside of the benefit at about $150 to $200, $300, depending what strength you're looking at. And then, of course, the injectables are available as well for about $350 per month, all at the expense of the members. The next level or the next category of management that we have is perhaps looking for a vendor that is able to administer an HRA type of program where you max out the dollar amount on that card. So say, for example, now that we know that there's lower direct-to-consumer pricing and the patient wants to be on an oral medication, the client can choose to cover the full amount at $200 or even just cover $100. And so that value can be placed on the HRA card, and it can only be used at the pharmacies, the direct to consumer. So it's tied to that. And if a patient does not use those dollars, it goes back to the plan. It's not like it will stay on the card until at the end of the month, and then it can be reissued for that patient. So just depending on the vendors and how they administer that program. But we do recommend, because there is still the employer groups, you are still paying for these drugs to some extent, then continue to put a prior authorization in place, because there's still plan costs associated with this program, depending on how you structure that. The other piece that we would consider is, let's carve this out. The employee groups can continue to cover this, but carve it out to a third-party administrator that has more stringent criteria. Most of them are willing to continue to pay some level of rebates to lower the cost, or layer on this third-party administrator, apply an HRA card, and then also require that the patient enrolls in a mandatory weight loss program, and they are able to receive these medications as long as they are actively enrolled and actively looking toward changing their lifestyle, dietary needs, etc. And but the one point with this is typically when you carve out to a third party, there may not be any accumulators that have changed between the TPA and the PBM. So that's something to consider. The last option is just keep it as is, keep it where it is with the PBM, knowing that the cost is there. This is the richest benefit, but the highest cost to the plan. At minimum, we would ask that at least apply the PBM's existing utilization management criteria. That's the one way that you can manage that cost, that spend, but still being generous toward the richest coverage for the members.
And Dr. Hong, I'll
Yes.
quick add in here for our fully insured employers out there, they are 99% most likely in this blue box on the left. And then
Mm-hmm.
for those that are self-funded, this is where you start to have some control and you could potentially make changes or put in programs to utilize or more or less curb some of the overutilization of GLP-1s for weight loss.
Agreed. And thank you for that, Ryan. And actually, as a side note here, like I'm for my clients who are covering weight loss, I've had difficult conversations, and actually, two of my clients recently moved from. One of them is considering an HRA funded program to start this year. The second group has actually decided to, we cannot find any savings. We don't find that these drugs provide value, and what they're doing is we are actually excluding these drugs. And from that perspective, we can help them as well. So it's very complex when you exclude a drug. For example, moving from coverage to non-coverage, you have to consider negotiations with the PBMs. They will adjust the rebates. We have to make sure that makes sense as well for our clients, that they're not being penalized for removing it, but at least a fair adjustment of the loss in rebates. All right. So I hope those options, we can definitely explore any of them with you if you have any questions. So let's switch gears a little bit and go into specialty drugs. Specialty drugs is it's interesting because it's ever changing. And here's really a definition of what is a specialty drugs, because speaking with from one PBM to the next, it can change. The list can vary. But in general, this is according to Medicare Part D guidance, right? It's a drug that's higher than $950 per month. It can be injectables, orals, inhaled. It just has to also have a unique storage or shipment requirements. There's additional education, or it's more complex condition that needs to be managed. That's often serious or chronic. And it's interesting because about it used to be only about $600 per month per Medicare Part D, but as we talk about pricing inflation and new drugs coming to market and the high prices associated with it, Medicare Part D recently adjusted it from 600 to 950. So it was very interesting for me to see that. Now, there are, as mentioned earlier, different PBMs categorize different drugs, and they're also reclassifying that ultimately impacts our contracts. And one of that is, for example, HIV. Some PBMs are willing to consider that as specialty drugs and willing to pay the rebates on these drugs as a specialty bucket, which is very valuable, right? It's a lot higher in terms of rebate yield that you can get from a specialty drug versus a non-specialty drug. We also saw recently where two PBMs last year, no, three, actually removed Dupixent from their specialty list to reclassify as a non-specialty list, as a non-specialty drugs. And again, this impacts what we had evaluated or projected in the RFP. That changes the rebate yield for our clients as well. So in summary, to me, specialty drugs, we would expect to continue seeing a rise in the growth because of the expanded indications. We are seeing emergence of new drug categories for conditions that previously did not have current therapies, right? And also, when these new drugs come to market, they're highly inflated and the drug price is very high. So we continue to expect to see a rise in drug spend with specialty. So what are some of the options that we can put in place for our clients, and what we have put in place for our clients? We have put in some programs, I'll call it enhanced pricing programs. And this is essentially carving out specialty and even some cases traditional drugs to access group purchase pricing or 340B drugs. And this program is not offered by the PBM because it really is counter to what they do. Is it actually cuts in their it actually cuts into their revenue. So we do have to renegotiate rebates on some of these programs because of that. But we always have to consider is the loss in rebates versus the projected savings of the program makes it more valuable. With this enhanced program, because it's 340B pricing, we do have to ask the member, the patient, to have a televisit with a qualifying provider to qualify for this 340B pricing. They can still keep their primary care, their specialist, but they just have to have that annual visit with this qualifying provider in order to access 340B pricing. We did implement this for our clients. And this group size was about 14,000 lives, and we achieved about $105,000 on average per month in savings. The enrollment is approximately 40 members per month enrollment in order to achieve that amount of savings. And then we also have coupon programs. At this point, coupon programs should be a standard offering. Most PBMs offer this type of programs. For the most part, it's specialty drugs, but some do have some traditional drugs as well. We don't recommend this for high deductible health plans. Some groups have consulted with their legal and applied it, but it does make it a little bit messy, especially with the accumulator piece. But we do recommend at minimum putting the accumulator piece for health for high deductible health plans. Now, this program uses existing pharma copay coupons to buy down the cost for the member and for the plan. And so we see it as a win-win. We did put this in place for many of our clients. We consider a standard program, as I mentioned. And for an example is we have a client that's about 16,000 life in size. Annually, it impacts about 260 patients. But we were seeing it on average about $83,000 per month in savings for this group, which is was about close to 10% of their pharmacies, their specialty spend. So it can provide good savings. And oftentimes these programs have shared savings from the PBM. The last one is called patients assisted funding where we really do carve out that specialty drug from the plan as well, but we're actually using funds from pharma or from foundations to actually obtain free drugs for our clients on behalf of the patients. It's typically a shared savings model, so there's a still cost to the plan, but the cost of the drug itself is removed from the plan. This is only offered through a third-party vendors. Some of our smaller boutique PBMs are open to it. They actually integrate and even have their own programs of patient assistance. And we're seeing quite a bit more of that being with the niche PBMs that are really coming to their own on the PBM scene. This program does offer aggressive savings because you're getting free drugs, but there is a lot more engagement or involvement on the member's behalf or even the provider's office filling out this paperwork to obtain free drugs. Now, we did put this in place for an example of a case study. We have a group of quite substantial in size, about 90,000 lives. And what we were seeing is about 875,000 on average savings per month, with about 400 members annually enrolled in the programs at different times. I wanted to say that before Humira became biosimilar, we were actually seeing about $1 million in savings per month for this group. So that was quite substantial. One thing to note here is that these programs can layer on top of each other. For example, the enhanced pricing program that we have, that group that we put in place, this group also had patient assisted funding. So for those patients who didn't qualify because they were high earners, what we did was then we layered this program on and obtained 340B pricing for them. And the coupon program can be embedded in the patient assistance program as well. So these do not have to be independent of each other, but again, it's evaluating the potential savings and seeing that it's a fit for the client and having the client fully understand what this program entails for the patient and the potential disruption versus the savings and the benefits. Ryan, any additional comments? Anything?
No, that's great. Yeah, these are all programs. I know that you put all the details too that sometimes are in place and sometimes you need to access in a third-party setting. So thanks for the extra thoughts.
Perfect. All right. So we're switching gears. What we can do now is let's focus on the PBM contracts. To me, I consider it chaos, and I intentionally did this slide to throw out all the why it's complex, and I truly think that the complexity allows PBMs to not be as transparent as they should. There is contract languages that can be opaque. It's not very transparent. There is market event loopholes that allow the reservation of rights to occur that PBMs can use to modify or change what was already agreed upon in the original agreement. There's more and more we're seeing drug class reclassification, either from a brand to a generic or generic to a brand, depending on how they would like to adjust that financial guarantees. We are seeing, as mentioned, specialty drugs being removed from a specialty list and now taking financial discounts of a traditional drug or rebates of a traditional drug, which is much less in cost, much less in value. So with all this, what is it that we can do to minimize this chaos? So to take a step back, what we have is a financial model. This model has worked quite well. This is really what the industry does when it comes to RPs. What we do is we take a look at drugs. We define it simply by brand or generic. Which bucket does this drug fall into? Which does this claim fall into? Was it submitted as a mail order, a retail 30, a retail 90, or specialty? So this information is given to the PBM as part of the RFP, and then they apply how they define what a specialty drug, what a brand drug could be. Do they use their own algorithm to reclassify? Do they use Metaspan as a standard, or do they use a mix of both? Right? And their specialty list, how do they define it? As mentioned earlier, PBMs, there's not an industry-wide standard consistent list. There is a core group of lists that we can agree to, but around that, such as HIV, transplants, and even some drugs that are LDD, they're not putting that as a specialty drug. So that changes from PBM to PBM. Exclusions around the caveats also around the offering in terms of rebates. What's excluded from rebates qualifies for rebates, what doesn't. So all this vagueness, it's a little bit difficult to identify the current and the future value around these the contract languages around these exclusions, right? And of course, formulary is such an important piece of this because an exclusionary formulary where there are categories of drugs that are highly rebatable. So the PBM negotiates to say, if we exclude this particular drug in this category, then you give us a higher rebate value for another drug in that category. So that's where a lot of the rebate dollars are played. And if you look at the majority of our clients are on this type of formulary, this is really the standard. And then you also have some that are open where there's not an exclusionary rebate driven type of formulary, but that tends to offer a less aggressive financial offer from the PBM. So all this information is taken and it's spreadsheeted out. PBMs 1, 2, and 3 are compared against each other. We put the baseline of a drug, compare that against the offering, adding an admin fee, rebates, gross costs, etc., and to show you where that savings, but the projected savings can be from PBM 1 to PBM 2. So that's really how the financial model works. But what's changing in this model is the reservation of rights language noted here. That's really important. That's changing the dynamic a little bit. Oh, I apologize. I did not move to this slide. I apologize on that. This is the financial model that I discussed, where they have changes within. They have a different definitions of brand and drugs, specialty, etc., that are part of the RFP responses from the different PBMs. So the reservation of right languages, what we're seeing is historically, it allows the PBM to alter their guarantees based on either the client changes if they carve out their specialty to another vendor, or if their claims volume change or their membership changes, then they'll adjust it. The PBMs can adjust the financial guarantees, or if there's any market events like a government mandate or some kind of industry-wide changes where the pricing changes, and so then the PBM will adjust the pricing. And what we saw is, for example, last year, LifeScan make test strips, and test strips are highly rebatable, but this company went out of business. And so what happened is the PBMs were not receiving rebates, so our clients did not receive rebates as a result. And so this changes the financial guarantees and the dynamics. We also saw something that was interesting where it didn't make sense to us, but it did happen, where the PBM's formulary clinical team created utilization management programs to manage drug spend, right? But it didn't align with their underwriter's assumption, so that created a negative impact to rebates. And of course, PBMs are revenue driven; they're for-profit companies, and so any negative impact to rebates has been adjusted and reserved due to the reservation rights, and that's passed on to our clients as well. And these are unforeseen events that are allowed within the current contract. And typically, we don't see a lot of that until this past year and a half, that we're starting to see a lot of this reservation of rights. Okay, so what are we seeing then? What we're seeing is that there's new languages within the PBM space where, because of the market event of biosimilars, the Humira and now Stelara, and to some extent, insulins are considered biosimilar as well because of its complex manufacturing process. And then we had government mandates on the Inflation Reduction Act, and we had the AMP cap removal. So this opened up the PBM to allow rebate credits. So rebate credits really is a reduce in rebate payments when certain market or drug events occur that allows the PBM to give themselves the credit that say, hey, these rebates are gone, so now we're going to deduct the amount of credit or the amount of rebates that you should expect. The problem with this is that we're not given the full information on how much rebate is received for a drug, right? So how can we evaluate an unknown because of lack of transparency against the newer product that they're adjusting for, right? So is there value in that? What kind of reporting can we have? And what are the differences in the actual rebate versus the difference in the cost? So that's a very opaque piece. And so because of this, our leadership within the practice, we said, let's move to a PMPM structure where the PMPM guarantee is a simple way of achieving a simple way of just making something so complex a lot simpler. So let me explain that. So what we're asking our PBMs to do for some of the RPs, when it makes sense for our clients, is that just give us a net PMPM guarantee per month. We don't care what happens with market events. We don't care how much rebates. We don't care what you may be doing with your formulary. But based on the existing plan designs and the programs that our clients have in place currently, give us that net PMPM guarantee. So the clients will continue to pay for their invoices, their claims throughout the year, but at the end of the contract year, it'll be reconciled to this particular PMPM. So say, for example, a client was given a net guarantee of $150, right? And if there's underperformance, which means that the client was paying a higher amount than the guaranteed cost, then the expectation is that the PBM would pay dollar for dollar the difference of that PMPM. So say, for example, the guarantee amount's $150. It ended up being $160 PMPM that the client paid for through the claims for the previous 12 months. Then the PBM will pay the difference of $10 PMPM back to the client from that perspective. This takes away the rebate games, the unclear rebate credit languages that can occur, changes in market dynamics, et cetera. And that reservation of right languages that's being used more and more frequently from these PBMs, it doesn't matter from our perspective. So I think this is an exciting time for us in terms of the RFPs and conducting it this way. And we are expecting many of the PBMs to comply with this if they would like to be aggressive and work with Gallagher on behalf of our clients. So that's all I have. I hope today I was able to share some insightful information on emerging trends with GLPs, how we can minimize that cost, best specialty drug utilization, what programs that we've put in place that are effective for our clients, and then of course the new model contracts to counter what is occurring in the marketplace when it comes to PBM contracting. All right, Ryan?
Great. Thank you, Miley. That was great. I know I think the big takeaway, from our perspective is make sure you're asking questions, make sure that you're
Yes.
reviewing your contract, make sure that you have the most advantageous terms for you. And then, like we've just discussed, explore some of these new pricing structures because things are changing and evolving. It's not just the traditional rebate pass-through model. And then even if you are fully insured, ask questions to how your carrier covers GLP-1s. What is the new stance because those drugs are changing? What is their process for what's the new indication for the GLP-1? It's not always just weight loss. So there's something that can apply as complex as the PBM and pharmacy industry can be, as you can see from the presentation today. It's all relevant. So great presentation. Thank you, Miley. This was great. And I know if there are any other questions, we'll hang out. Feel free to put them in the chat, or if you'd like to come off mute, just let me know and I can click your button. But we'll hang out while we wrap up and answer any questions you have. But thank you all for being here. All right. Looks like mostly thank yous and people are filtering out. So thanks again, Miley. This was great. I appreciate you jumping in for us. And to the rest of the crew out there, if you have any other questions, feel free to reach out. I think contact information is out there. And so thank you all for being here. Have a great rest of your day.
Thank you. Take care. Bye, everyone.
Bye.